Following a spinal cord injury, depending on the extent, type, and level, patients may experience orthostatic hypotension associated with autonomic nervous system dysfunction. Physiologically, blood pressure control depends on the spinal sympathetic neurons. We will learn how after a spinal cord injury, these neuronal pathways may become disrupted and are unable to generate the necessary sympathetic activity responsible to maintain adequate blood pressure. Hi, my name is Jeff. I'm an occupational therapist who makes free content on YouTube, but also on my website and podcast. Be sure to check out the links in the description for much more helpful content. Let's get functional. In healthy individuals, blood pressure is controlled by coordination of the sympathetic and parasympathetic systems that are opposite to each other and are activated when needed. These are commonly referred to as the fight or flight system. More specifically, when the sympathetic nervous system is activated, heart rate increases. The heart's myocardial muscles contract with more force, which then cause more peripheral vascular resistance. This achieves an increase in blood pressure by the sympathetic nervous system. With spinal cord injury, there is a disruption of the descending spinal cardiovascular pathways that causes underreactivity of the sympathetic nervous system. This sympathetic hypoactivity ultimately results in low blood pressure. Even at rest, someone with a spinal cord injury may lose the ability to adapt to the adequate needs to maintain blood pressure and reflex control. Let's talk a little bit more about orthostatic hypotension. Orthostatic hypotension is defined as a decrease in systolic blood pressure of 20 millimeters of mercury or more and 10 millimeters of mercury or more diastolic in blood pressure. The patient assumes an upright position after starting from a supine position. In spinal cord injuries, about 59% experience symptoms of orthostatic hypotension. These symptoms include typically feeling lightheaded or dizzy. Studies show an increased overall risk of orthostatic hypotension for those who have sustained a traumatic spinal cord injury compared to a non-traumatic one. An example of a non-traumatic spinal cord injury is, say, spinal stenosis, as this originated from within the body and there was no outside external trauma. There is also a correlation between orthostatic hypotension and the elderly. However, the 19-year-old who I worked with also may experience significant symptoms and complaints of feeling, say, lightheaded or other symptoms associated with orthostatic hypotension. In terms of occupational therapy, this can impact performance and participation as the patient is unable to tolerate, say, out-of-bed activities of daily living, IADLs, work, school, even socialization. So what can we do for the management of orthostatic hypotension after a spinal cord injury? The good thing is that management is very similar for other conditions and populations, despite the etiology being different for other conditions that may not necessarily involve physical changes to the spinal cord itself. The rehab team should overall look at non-pharmacological interventions at first, and then if this does not work, then use pharmacological methods, probably in conjunction with these methods that I will mention. Occupational therapists are well positioned to provide spinal cord injury survivors with education about orthostatic hypotension, what causes it, what the symptoms are, and how to manage it. In terms of lifestyle changes, caffeine and alcohol should be avoided as these are diuretics and could provoke an episode of orthostatic hypotension. Similar to multiple sclerosis, studies have shown that heat may cause vasodilation responses and a stress on the overall system. So I would say to avoid extreme heat for people who are very prone to orthostatic hypotension. Compression garments and support stockings are also a great area of education and practice that occupational therapists can provide for spinal cord survivors. One good place to start is to obtain, demonstrate, and practice with abdominal compression garments. These can be found in the hospital supply room, or if not, by calling your central supply team member to see if they have it elsewhere in the hospital and if it can be brought to you. Studies have shown abdominal compression to be an effective way to manage orthostatic hypotension at certain compression pressures, not all compression pressures, however. According to Figueroa et al., mild compression or 10 millimeters of mercury of abdominal compression prior to rising helps with orthostatic hypotension. In their study, they found no additional benefit to adding additional compression over 10 millimeters of mercury. Also, it is important to keep in mind that people have different tolerances for the amount of compression that is applied to them. And because in real practice, occupational therapy practitioners will not be measuring exact pressures in millimeters of mercury, for example, the best way to go about this is by patient self-report of comfort and tolerance. If patients can adjust the pressure themselves instead of the therapist, that would be ideal as it is both patient control and this promotes independence and decreased dependency on caregivers. And while I haven't done this in practice, I wonder if a way to measure, say, 10 millimeters of mercury, wonder if it's possible maybe to say slip a blood pressure cuff in there and then like a manual one and then apply the pressure and see if it gives a reading. You may be able to do this with like a pumped up blood pressure cuff, kind of like the similar way how you can squeeze it with the hand to measure like as a makeshift dynamometer. I wonder if you can do a similar thing with a blood pressure cuff inside this garment to measure some sort of pressure. I know it's not going to be exact, but I haven't really found a good way to measure exactly 10 millimeters of mercury or more in practice. I kind of go off of just symptomology and a feel for it based on my experience. If any of you know in the comments a good way to measure it like more accurately to get more closer to this number so that we're following the best in studies and practice, that would be pretty cool. The easiest way I have found for spinal cord injury survivors to put on abdominal compression is beginning in side lying and rolling over an opened up abdominal compression garment. This is kind of like how you would teach patients to don a TLSO by rolling over it at bed level. Once your patient rolls onto the abdominal compression garment and is fairly centered, depending on the level of the spinal cord injury, they may be able to wrap themselves up using their upper extremities using the included Velcro or hook and loop straps. And then once they are in self-supported sitting or in external supported sitting, such as in a wheelchair, they can then quickly readjust the garment to center it for more comfort or even readjust the pressure if it is, say, too little or too much. Remember, we want to achieve at least 10 millimeters of mercury or more. I often start with the abdominal part compared to the lower extremity compression, such as with support of stockings, because overall I find that abdominal compression is much easier than lower extremity compression. And regarding like TED hose, even for me, donning say TED hose can be very difficult like as a helper. Even using all the tricks such as baby powder or plastic bags to slide it over to decrease friction. It's not impossible, but it is much more difficult. I also have a video on how to do the plastic bag trick for TED hose if you're interested, and I'll post this in the description. Another easy thing to do before getting out of bed, either during therapy or if possible by educating spinal cord injury survivors to do this themselves before therapy sessions, is to increase their overall fluid intake. Studies show that increasing salt intake helps as well. Of course, not to overdo it, right? Ways this can be done can be simple as drinking a cup of water or other dietarily approved beverages before therapy. At night, with sleeping, sleep position can affect orthostatic hypotension symptoms as well. This makes sense as positional changes are often the reason that spinal cord injury survivors experience orthostatic hypotension when they get up. So sleeping with the head of bed raised up, or if no electric bed with say pillows or a wedge, can help. And starting at say 10 to 20 degrees has been shown to be effective in reducing orthostatic hypotension symptoms in the research. In summary, spinal cord injury survivors may experience orthostatic hypotension when getting up out of bed, and this is kind of common. It can limit, of course, participation in therapy and daily occupations. However, with education and a team approach to management, the rehabilitation team can use multiple methods, including dietary changes, sleep position changes, and external compression garments to help manage these symptoms for overall participation and recovery. The key is to be consistent and provide multiple opportunities for self-practice to make it more routine. By empowering spinal cord injury survivors to manage their orthostatic hypotension symptoms, they can get back to participating in the occupations that are meaningful to them, such as mobility, ADLs, socialization, and more. Hope this helps. This video was an overview of orthostatic hypotension following spinal cord injury. I'll be making a deep dive video more in the physiology, management, and occupations of this phenomenon. If you found this video helpful, give it a thumbs up so that I know to make more of this type of content. Thanks for watching. I'm Jeff, the OT Dude, and have a nice day.